So if you get a paper cut on your finger, well, your body usually has it completely closed up and healed in just a matter of days.
Right, it's usually a pretty fast process.
Yeah, but right now, there are millions of people suffering from microscopic tears in their body that just, haven't healed in months.
It's a massive, massive issue.
And to fix it, science isn't using traditional stitches or, like, scalpels. They're actually hacking the body's biological postal service to mail these nanoscale architectural blueprints directly into the open wound.
Which is just fascinating.
Right, so today we are taking a deep dive into an issue that is, frankly, really uncomfortable to talk about for a lot of people. But the way researchers are learning to heal it is sparking this massive biological revolution.
Exactly.
Our mission for you today is to explore the cutting edge of regenerative medicine and answer one very specific question.
Right. What is the therapeutic rationale for using exosomes to treat chronic, non-healing mucosal fissures at the posterior commissure?
Which I know sounds like a dense medical riddle.
It does, yeah. But what we are really talking about is moving away from traditional mechanical surgeries.
Like cutting things.
Exactly. Surgeries that historically required cutting a perfectly healthy muscle just to fix a skin problem. And we're moving toward a future where we heal damaged tissue from the inside out at the molecular level.
To help you understand how this works, we have an incredible stack of sources in front of us today. We're pulling from recent clinical trial data on novel cell therapies, things like genetically engineered cells and platelet-rich plasma.
Also known as PRP, yeah.
Right. And we are also digging into some heavy-hitting literature on mesenchymal stem cell-derived exosomes and their role in wound healing.
But to grasp the cure, we really need to understand the environment of the wound itself.
Yeah, you can't fix a failing ecosystem until you know why it's dying in the first place, right?
Precisely. So let's start by defining the actual condition. Anatomically, a chronic anal fissure is a mucosal ulcer in the anal canal. Specifically, it's located in an area we call distal to the dentate line. Now, crucially for our discussion, these tears most frequently occur at a very specific anatomical spot called the posterior commissure.
Which is just the back wall of the anal canal, right?
Yes, simply the back wall.
I think most people's gut reaction is, well, a tear is just a tear. Even if it's in a sensitive spot, shouldn't it just heal over time like any other cut?
You'd think so, yeah.
But our sources define these as chronic, meaning they stay open and painful for longer than 8 weeks. Why does the body just give up on healing this one specific area?
It mostly comes down to a severe lack of blood flow, which is driven by immense physical pressure.
Pressure from the muscle.
Exactly. The primary pathophysiological driver here is abnormally high anal sphincter pressure. When that muscle is constantly clamped down in a state of spasm, it creates an intense, continuous squeezing force.
Wow.
And that force actually crushes the local arterioles.
The tiny blood vessels.
Right, the tiny blood vessels supplying the area.
So the sphincter muscle is squeezing so hard that it literally flattens the surrounding blood vessels, completely shutting off the pipes.
That's exactly it. And because those pipes stay shut, the tissue undergoes a state called mucosal ischemia.
Ischemia meaning lack of oxygen.
Right, it is literally starving. Wound healing is an incredibly energy-intensive process for the body. You need oxygen, you need nutrients, you need immune cells.
And if the pipes are crushed?
When you cut off the biological supply lines, the repair mechanisms just grind to a halt. The fissure gets trapped in this chronic, non-healing state.
Okay, let's unpack this. So it's like a massive pothole forming on a busy, high-pressure highway.
That's a good way to look at it.
You can't pave over the hole because the relentless traffic, which in this case is that intense sphincter pressure, it never stops.
Never stops.
And because the traffic never stops, it blocks the supply trucks from bringing in asphalt, and the repair crews can't even get to the site to do their jobs.
If we connect this to the bigger picture, that highway analogy perfectly explains why traditional medicine has struggled with this condition for decades.
Because they've been trying to fix the traffic, not the pothole.
Exactly. The historical treatments, things like prescribing topical nitrates, injecting Botox, or even performing a surgery called a lateral internal sphincterotomy, they all essentially try to stop the traffic.
Right.
The goal is to force the sphincter muscle to relax just enough to allow blood flow back into the area.
But, I mean, I'm looking at the notes on that sphincterotomy surgery, and permanently cutting a portion of a muscle that controls your bowel movements sounds like an incredibly risky trade-off.
The risk is substantial, yeah.
Right.
While cutting the muscle lowers the pressure and allows the fissure to finally heal, it carries a very real risk of permanent fecal incontinence.
Oh, wow.
You are essentially trading one devastating quality of life issue for another.
Which is exactly why researchers started asking, what if we don't cut the muscle at all? What if we can somehow force the biological repair crews to work despite the high pressure? I notice our sources highlight a massive pivot toward regenerative therapies to achieve this.
Yes, they do.
They're looking at taking regenerative materials and injecting them directly into the edge of the tear.
And the early clinical data on these regenerative approaches is quite striking. For instance, some of the trials focused on utilizing platelet-rich plasma, often called PRP.
Right, alongside adipose-derived regenerative cells.
Yes.
I was reading through those PRP trials, and the drop in bleeding for the patients was massive. But I don't recall the exact timeline. How fast did it actually work compared to the standard treatments?
Well, the trial injected the patient's own concentrated platelets directly into the site. At the 6-month mark, bleeding rates had dropped to just 4%.
Oh, percent.
Yeah. Compare that to the control group, which received standard topical treatments, and they still had a 32% bleeding rate.
That is a huge difference.
It is. More importantly, the PRP group achieved a 96% healing rate overall.
96%. That proves the concept right there.
Absolutely.
If you deliver powerful enough regenerative signals directly into the tissue, the body can overcome the ischemic starvation.
Right.
The sources also mention a trial using something called ECL-UVS. These are genetically engineered human umbilical vein endothelial cells.
Correct.
They actually equip them with a pro-survival gene so they can survive in that harsh environment, physically regenerating the damaged tissue.
Yes, it's very advanced.
But here is where I'm getting a little lost. If injecting live umbilical cells or concentrated platelets work so well, why are we devoting this entire deep dive to something called exosomes?
That is a great point.
Why not just use the whole live cell and call it a day?
That is the critical question facing regenerative medicine today. While live cell therapies are incredibly promising, they come with a host of logistical and biological nightmares.
Like what?
First, live cells are notoriously difficult to store and transport. You can't just keep them on a shelf. They require strict cryogenic freezing.
Oh, so they're super fragile.
Extremely. Second, whenever you introduce foreign living cells into a patient, the patient's immune system might recognize them as invaders and attack, leading to immune rejection.
I imagine there's also a risk of those cells doing something we don't want them to do once they're inside the body.
Unfortunately, yes. There is always a theoretical risk of tumorigenicity.
Tumors.
Right. Live cells are programmed to rapidly multiply. If they lose their regulatory controls, they could potentially form tumors.
Wow. So they're incredibly fragile. They need absolute freezing conditions. The immune system hates them, and they might go rogue and multiply out of control.
Which paves the way for a much safer, cell-free alternative.
The exosomes.
Exactly. Scientists realized that mesenchymal stem cells, the powerful cells driving tissue repair, they don't necessarily heal tissue by physically turning into new skin or blood vessels themselves.
Okay.
Instead, they operate more like a foreman on a construction site. They coordinate the repair.
Wait, if the stem cell is the foreman, how is it communicating with the local tissue? I mean, it doesn't have vocal cords. Is it just dumping chemicals into the surrounding fluid and hoping the native cells absorb them?
Not at all. It's much more sophisticated than that. They secrete specific chemical signals neatly packaged inside exosomes.
Okay.
Exosomes are the body's nanoscale messengers. We are talking about extremely tiny extracellular vesicles, only about 30 to 100 nanometers in size.
That is unbelievably small.
To put that physical scale in perspective, a single human hair is roughly 80,000 to 100,000 nanometers thick.
Oh, wow.
Yeah. These tiny vesicles are naturally released by stem cells into physiological fluids, acting as a highly targeted biological postal service.
Okay, so what exactly is in the mail? What are they carrying to the damaged cells at the tear?
They carry highly specific cargoes of genetic information. The most important elements are microRNAs, along with various long non-coding RNAs, lipids, and proteins.
So it's basically a packet of code.
Exactly. When an exosome floats through the fluid and attaches to a damaged target cell, it empties this genetic cargo inside. That microRNA then acts as new operating code, effectively reprogramming the recipient cell's behavior from the inside.
But why bother with the vesicle at all? I mean, if the magic is in the microRNA, Why not just manufacture raw microRNA in a lab and inject it directly into the fissure?
Because the microenvironment of a chronic wound is an actively hostile war zone. It is highly inflamed and swimming with degradative enzymes.
Right.
If you injected naked, negatively charged microRNAs directly into that acidic environment, those enzymes would chew up and destroy the genetic code almost instantly.
Ah, so it needs protection.
The brilliance of the exosome is its lipid membrane structure. Because the vesicle is made of a fatty lipid bilayer very similar to our own cell walls, it acts as biological armor.
That's amazing.
It protects those incredibly fragile payloads until they can safely merge with the target cells.
I love this. So it's like exosomes aren't the construction workers, and they aren't even the architect. They are the indestructible envelopes carrying the architectural blueprints.
That's a perfect way to visualize it.
You don't need to transplant the whole architect, the unpredictable live stem cell, into a dangerous war zone.
Hmm.
You just mail the blueprints inside these armored envelopes directly to the local cells, telling them exactly how to rebuild.
Yes. By utilizing just the exosomes, you harness the therapeutic power of stem cells without the need for cryogenic freezers, without triggering immune rejection, and without the risk of rogue tissue growth.
All right, so we have our armored blueprints. Let's get into the actual therapeutic rationale of how they work.
Okay.
We established earlier that the main villain at the posterior commissure is ischemia, the severe lack of blood flow due to that crushing sphincter pressure. How does a microscopic bubble of fat fix a lack of blood supply?
What's fascinating here is how exosomes directly and aggressively trigger angiogenesis.
Which is the formation of new blood vessels, right?
Yeah. Exactly. The exosomes derived from mesenchymal stem cells are absolutely packed with pro-angiogenic factors. When they merge with the local cells, they deliver specific molecules like vascular endothelial growth factor.
Also known as VEGF.
Right, VEGF, as well as angiopoietin-1 and crucial microRNAs, particularly one called miR-126.
And the results in the preclinical studies are just staggering. I was looking at the vascular density charts in the source material, and they showed that MSC-derived exosomes can increase microvascular density in a wound by 30 to 70%.
It's a massive increase.
They are literally forcing the body to lay down an entirely new network of biological supply lines. But I really want to understand the how.
Sure.
The sources mention that exosomal miR-24-3P targets something called VHL-E3 ubiquitin legis, which, I mean, sounds like total gibberish to me. How does that molecular alphabet soup actually create a blood vessel?
Think of that VHL enzyme as a set of biological brakes. Normally, it prevents the cell from overproducing blood vessels.
Okay, that makes sense.
The exosome drops off a specific microRNA that binds to that enzyme and disables it. It essentially cuts the brake lines.
Wow.
Once the brakes are disabled, a critical protein called HIF-1 alpha, which is the protein that responds to low oxygen, can rapidly build up.
So by disabling the brakes, HIF-1 alpha just hits the gas pedal.
Exactly. The accumulation of HIF-1 alpha drastically heightens the signaling of vascular growth factors. It flips a master switch that screams to the local tissue, "We are starving for oxygen. Start building new blood vessels now."
That is so cool.
This molecular cascade directly combats the starvation caused by the sphincter spasms.
Here's where it gets really interesting for me, though. From the research, they don't just build new blood vessels. You still have an open, painful physical tear in the mucosal lining that needs to close.
Right, the tissue defect.
The literature highlights that exosomes deliver another molecule called miR-21, which targets a protein called PTKN to unleash a survival pathway. I'm lost again. How does a microscopic blueprint trigger survival in a torn piece of skin?
Think of P10 as a strict biological supervisor that tells cells to stop growing and stay put.
Oh, wait.
The exosome delivers a microRNA that essentially locks that supervisor in a closet.
Ah.
With PTN out of the way, a pathway known as PI3K ACT is unleashed. This is a primary pathway for cellular growth.
And the sources also point out they deliver a protein called 1,4, which triggers beta-catenin.
Yes. Between locking up the growth supervisor and delivering those growth proteins, you are basically throwing the accelerator to the floor for fibroblasts and keratinocytes.
And those are the specific cells responsible for generating skin and connective tissue.
Exactly. The exosomes physically force them to rapidly multiply and migrate across the open mucosal tear to seal it shut.
Okay, wait, I see a massive logical problem here.
What's that?
We just established that the exosomes build a massive new highway of blood vessels, and they force skin cells into overdrive. But we also know chronic fissures are red, angry, and heavily inflamed.
Yes, very inflamed.
If you pump a massive amount of new blood flow into an actively inflamed wound, Aren't you just throwing gasoline on a fire? Doesn't it
Yeah.
just bring more angry immune cells to the site and make the inflammation worse?
That would absolutely be the case, except exosomes perform another vital function. They act as master immunomodulators.
Oh, interesting.
They don't just build, they manage the environment. Chronic fissures fail to heal in large part because the local immune system is stuck in an unresolved state of excessive inflammation, destroying tissue rather than repairing it.
So how do the exosomes stop the immune system from destroying the new tissue? Do they just kill off the immune cells?
No, no. They reprogram them through a process called macrophage polarization.
Okay, let's break that down.
Macrophages are a type of white blood cell acting as the first responders in a wound. In a chronic tear, these cells are predominantly stuck in what we call the M1 phenotype, which is highly inflammatory.
Right.
They release cytokines that break down tissue. Exosomes merge with these M1 macrophages and force them to shift, or polarize, into the M2 phenotype.
And the M2 phenotype is the healing, tissue-repairing state.
They completely switch teams. Studies report that applying these exosomes can increase the ratio of healing M2 cells to angry M1 cells by 1.5 to 3.2-fold.
That's incredible.
It is. This shift is driven by specific exosomal microRNAs like miR-223, which actively suppress the NF-kappa B signaling pathway. Think of that pathway as a central alarm bell for the immune system. The exosome literally cuts the wire to the alarm.
I picture this like a riot
A
protocol.
riot protocol.
Yeah, like the M1 macrophages are a rogue demolition crew. They're swinging sledgehammers, causing collateral damage and creating this mess of inflammation.
Sure.
Then the exosomes arrive on site. They act like a supreme site manager. They blow the whistle, force the demolition crew to drop their sledgehammers, put on hard hats, transition into M2 macrophages, and start pouring concrete to stabilize the area.
That's a great analogy. And that concrete is quite literal in a biological sense.
Oh, really?
Yeah. By shifting the environment to that M2 state, exosomes boost the deposition of collagen by 1.4 to 2.0-fold.
Wow.
Collagen is the structural scaffolding of human tissue. Furthermore, looking specifically at mucosal epithelia, the exact type of tissue lining the anal canal studies show that applying exosomes leads to a highly significant decrease in the physical width of the wound.
Because it's literally pulling the tissue back together.
Exactly. Crucially, researchers noted that the more frequently they applied the exosomes, the better the tissue healed.
Which makes sense logically. You need to keep delivering those blueprints to keep the construction crews on task.
Right.
But that actually leads us to a massive practical problem. Knowing the molecular blueprints work in a petri dish or a controlled, sterile lab setting is one thing, but we are talking about treating a posterior commissure fissure.
Yes, a very challenging area.
The anal canal is a highly active, mucus-lined, bacteria-rich environment. There's constant mechanical movement, friction, and, the daily passage of stool.
It's extremely harsh.
If you just spray a liquid solution of nanoscale fat bubbles onto that fissure, won't they just instantly wash away?
That is the big question. This is perhaps the single greatest translational barrier in bringing exosome therapy from the laboratory into real-world clinic.
Finding a way to keep them there.
Retaining these microscopic vesicles at a wet, mobile, mechanically stressed mucosal site is incredibly difficult. If they don't stay in the wound bed long enough to actually merge with the local cells, the treatment is entirely useless.
So how do we anchor them down? I mean, we can't just slap a Band-Aid inside the anal canal.
No, we can't. The solution the scientific community is converging on lies in biomaterial-assisted delivery platforms.
Biomaterials.
Yes. You don't inject free-floating liquid exosomes, you combine them with smart materials. For example, our sources detail the use of thermosensitive hydrogels, materials like DMA, combined with hyaluronic acid. Researchers are also using specialized polymers like pluronic F127 gels.
I saw the term thermosensitive hydrogel in the notes. How does temperature help keep the exosomes in place?
These materials possess a fascinating physical property. They exist as a highly fluid liquid at room temperature.
Okay.
This means a doctor can easily mix the exosomes into the liquid and inject it directly into the tiny margins of the tear. But the moment that liquid hits the 98.6-degree warmth of the human body, it undergoes a rapid phase change.
Oh, wait, really?
Yes, it instantly gelates, forming a semi-solid porous matrix perfectly molded to the shape of the wound.
Meaning the liquid turns into a firm gel right there, and the exosomes are trapped inside the pores of that matrix.
Precisely. These smart hydrogels extend exosome retention and functional bioavailability by 2 to 5 times compared to injecting a standard liquid solution.
That's huge.
It is. They create a sustained, localized release. The hydrogel acts as a reservoir right at the fissure margins, taking the brunt of the mechanical friction and protecting the exosomes from being washed away.
So they can do their job over time.
Exactly, allowing them to slowly diffuse into the surrounding tissue over days or even weeks.
It's like wrapping our architectural blueprints in a timed release, sticky gel. You pack that into the pothole, and the gel takes all the physical abuse. It gets hit by the traffic, the friction, the moisture, but it holds strong, slowly dripping those RNA instructions into the local cells day after day, completely regardless of how hostile the environment is.
That bioengineering step, marrying nanoscale biological messengers with advanced material science, is really what makes cell-free therapeutics practically viable for the unique, challenging microenvironment of the posterior commissure.
Without the hydrogel, they just vanish.
Without the hydrogel, the exosomes are washed away. And without the exosomes, the hydrogel is just an inert plug. Together, they create a robust, impenetrable, regenerative environment.
So what does this all mean for you listening right now? Let's bring all these pieces together. The therapeutic rationale for using exosomes on a chronic posterior commissure fissure represents a total paradigm shift in how we approach healing the human body.
It truly does.
It's about bypassing the risky, mechanical, muscle-cutting surgeries that can leave patients dealing with lifelong incontinence. And it's about avoiding the logistical nightmares, the freezing requirements, and the immunological risks of injecting live, unpredictable stem cells.
Right.
Instead, we use a cell-free delivery system. We take microscopic armored blueprints and deliver them directly into the wound. These exosomes reverse the underlying starvation by literally cutting the biological brakes to build new blood vessels.
They step right into that highly inflamed war zone.
Yeah, they jam the immune system's alarm bells and flip the local macrophages from a demolition crew into a repair crew. They lock up growth-restricting supervisors to trigger rapid skin multiplication.
All working in tandem.
And crucially, we hold all of this microscopic magic exactly where it needs to be, using smart, temperature-sensitive hydrogels that mold perfectly to the wound.
It's elegant.
It really is. It is elegant, it's incredibly precise, and it addresses the biological root cause of the non-healing state rather than just treating a symptom.
If we step back and look at the trajectory of this research, it raises a truly profound question.
What's that?
Well, if we can master this delivery system, if we can use smart hydrogels and exosomes to completely regenerate tissue in an environment as mechanically hostile and bacteria-rich as the lower gastrointestinal tract, what is the limit?
Oh, wow.
Could we one day program these microscopic vesicles to seek out and heal internal mucosal ulcerations before they ever break the surface?
That would be revolutionary.
Imagine applying this exact same cell-free technology further up the digestive tract. We could potentially be looking at a future where we can end systemic conditions like inflammatory bowel disease or Crohn's at the molecular level, replacing devastating chronic illnesses with targeted nanoscopic healing.
From a pothole on a busy highway to a microscopic blueprint for ending chronic disease. Thank you so much for joining us on this deep dive. Keep questioning the world around you, and we'll see you next time.